Good evening, and thank you for joining us here on blackdoctor.org. I am Ellis Dean, the Director of Digital Programming, at blackdoctor.org, and we are excited to bring you show number 3 in our series on multiple myelomas entitled Blood Brothers, Overcoming Multiple Myeloma. Now, you might be asking, what is multiple myeloma? Well, you might need to go back and watch the other 2 programs that we did with Dr. Craig Cole about what is a multiple myeloma. It is a blood cancer that disproportionately impacts people of color. I'm giving you the 50,000 foot, and particularly Black men. That's the title, Blood Brothers. And so tonight we're going to be talking about kind of overcoming disparities, research, what's next on the horizon when it comes to the treatment and research in dealing with multiple myeloma. And all that, Dr. Cole is so fantastic. He's just such a wonderful gift for you all, and so for us as well. And so just excited to see what he has prepared for us tonight to get us smarter about multiple myeloma. Couple of things I need for you to do before we bring on the man of the hour, and that is number 1, let us know where you're watching from. So we like to know where people are watching us from all over the world, and we need you to drop your city and state. Give yourself a shout out in the comment section. Number 2, if you know somebody that needs this information, please tag them or share this on your page, because it is information that we all need, and we can't get it out to everybody. So we need you to help us do that by sharing it on your page and getting out to the people that follow you. And then finally, if you have any questions, please drop those in the comment section as well. We like to get them asked and answered, because this show is all about you and getting you the information that you need. Finally, I will say as a disclaimer, if you are in treatment, if you are currently suffering in treatment for multiple myeloma and are under the care of a physician, anything that we say tonight should not be used in replacement of your care with your physician. This is just to spark that conversation, to ask that question, but do not stop or change anything that's going on with your current treatment plan as a result of what is being shared tonight. This is for informational purposes to help you and give you some more perspective about the condition. All right. So with that being said, let's bring on the man with a plan, also known as Dr. Craig Cole from Michigan State University. Good evening, Dr. Cole. How you doing?
I'm very good, Alice. How are you?
I am doing well. We missed you last month, but I know September, those of you who don't know, September is Blood Cancer Awareness Month, and that is probably Dr. Cole's most busiest month.
Yeah, we were busy. We actually had our big myeloma meeting in Athens, Greece. And so I was picking up knowledge. I just got back a couple weeks ago. So
Wow, Athens, Greece. That's swanky. That's nice. Okay.
That was really nice. So thanks. We're glad to be back.
Well, we're glad to have you. We definitely missed you. And like I said, if you want to go back and watch the first 2 parts of the series, it gives you a great breakdown of what is multiple myeloma and the treatment. So I encourage anybody that's watching this, go back. He did a fantastic presentation. Well, we've got another one. Another hit, another hot one coming up tonight with Dr. Cole. So let me get you started and bring that up there and take it away.
No, and thanks again for inviting me. And I'm Craig Cole from Michigan State University Carmelos Cancer Institute. And today we're going to be talking about some of the existing disparities with multiple myeloma and how we can overcome those. And if you could go to the next slide. And those are my disclosures. And the next slide. So we're going to talk about why do cancer disparities exist in toto, and then I want to make the case that between the races that there are different types of myeloma, and that Black people and really people of African descent, not in just the United States but around the world, have a different myeloma. That there are differences in myeloma risk, differences in myeloma biology, differences in myeloma presentation based on race and ethnicity. And then some of those disparities. So we're going to talk about health disparities, and we can see how those relate to myeloma care. and then talk about solutions to those disparities. So next slide. So this is one of my favorite quotes. Almost always when I talk about disparities, I have this quote because I think it is absolutely true that of all forms of inequality, injustice of healthcare is probably the most shocking and inhumane. That really everyone, regardless of race, ethnicity, and gender, should receive the best healthcare that is possible. Next slide, please. So why do cancer health disparities exist? And it all begins with racism, discrimination, segregation. And I would say that the Flexner report, I think of 1910, I believe, really started the separation of healthcare between races. That report, closed down a lot of the Black medical schools in the United States. Refrained Black people and people of other ethnicities from medical school, as well as refraining women from medical schools, and really said that that Black people should take care of Black people, but didn't give the opportunity to educate them. And
Right.
that really began this two-tiered system of health delivery in the United States. And you add on the structural inequalities and social injustices to that. And then you have, disparities in the social determinants of health. And the ones that I kind of highlighted and read are ones that are particularly relevant to myeloma. That there are clinical differences, that there isn't equal access to care or healthcare quality, especially with myeloma, because myeloma is such a specialty in blood cancers. These myeloma therapies are very and can be very expensive, not only to the patient, but to the healthcare system in the hospitals that serve the people. So there are significant social determinants of health that make care unequal. There are cultural beliefs and health-related attitudes, especially dealing with health, and especially diseases like myeloma, which aren't as obvious and a little bit more nuanced in the African American community. There are some behavioral differences that might contribute to myeloma. We'll talk about that. And we'll talk about the significant biologic differences between the races with multiple myeloma. And not to say that environmental and psychosocial aren't other determinants of health that play in myeloma, but I think the ones I haven't read are the main ones. And how it especially is applicable to cancer health disparities is in early detection, education, risk reduction, risk assessment of cancer, treatment, and survivorship. And because we have a lack of diversity in cancer research and a care workforce stemming from number one, racism and discrimination, that we will, of course, have disparities in cancer care. And the good thing is that we'll talk about at the end how we're really trying to address a lot of these social determinants of health. And next slide. I don't think that we really talk enough about, and I say we in the not only in the community, but I would say that my colleagues in myeloma don't talk about how racism impacts cancer disparities. And it does. I mean, it contributes significantly to health, and not just in cancer, but across the board. But for myeloma, in the prevention of cancer, finding cancer early detection, and then getting treatment. There's structural racism in the ways that the society, education, employment, and healthcare, housing, and law enforcement are structured to benefit one group, empower, and hinder other racial groups. And that's kind of the biggest one. Then institutional racism, that the ways and practices and policies of institutions which may block racial and minority groups from access to resources. And especially when we talk about a lot of the academic centers having a lot of resources to treat myeloma, and that we don't have, and sometimes we don't feel that we have access to them because of institutional racism that again is related to the Wexner report and how they've really tried to have women and people of color excluded from those institutions, and how we need to get on their doorsteps to then say that we want to have our care take to break down institutional racism. Interpersonal racism, when providers, nurses, and patients can be seen by individual interactions, and conscious or unconscious racial prejudices result. So that somebody, a scheduling person may schedule a patient that looks like them earlier for an earlier appointment than someone who doesn't look like them, or that they can't relate to. And then there's intrapersonal and internalized racism, when people of a racial, ethnic, or minority group accept stereotypes about themselves who share their identity and belief. And again, I would say that that structural racism, difficult to break down. Institutional racism can be broken down. Interpersonal racism, we're really working at to try and break that down. And intrapersonal racism, we need to really begin to dissolve.
So Dr. Cole,
Yes.
I'm sorry, but like in the institutional racism, what role do you think that the rising cost of tuition plays in as creating a barrier for groups of color to get the education? Because it's when it's $40,000-$50,000 a year to get that college degree, you might not go.
Absolutely, because that is some of the institutional barriers that, and I don't even know if some of these institutions even remember putting up those barriers, that they were put up, literally in some places hundreds of years ago, to try to make their constituency, their student population, very elite. And how, and these days, I don't want to get into politics, but they're still trying to maintain those institutional barriers. And really, I think the big thing is to call people out on that. And I talk to people who are prospective medical students, I tell them that, I didn't grow up rich, and I took out a lot of loans. But I kind of knew that it was going to be worth paying off those loans in the future. That, being able to be a person of color in a medical school, and I knew I was going to have to pay that back, but I didn't have the worry of how much the university cost serve as a barrier. I didn't have that intrapersonal racism say that I couldn't make it. And actually, along the way, I found scholarships, over the decades that I've been practicing, to help pay off my student loans early. So we'll talk specifically about recent incidents in myeloma. And again, just like Ellis had mentioned, myeloma is a blood cancer, a cancer of the plasma cells that live inside the bone marrow as part of the immune system. And those plasma cells, when they become malignant, produce excessive amounts of protein. They cause bone destruction. They cause high blood calcium and kidney damage, which can masquerade for a lot of other diseases. And is very treatable. And we'll talk about the treatments of myeloma towards the end. But it is a blood cancer that disproportionately affects people of African descent. And you can see in the first graph there that among men, 16.5 per 100,000 Black people are affected by myeloma, and 12 per 100,000 of Black women, as compared, and that number is halved by white men and women, all races much lower than Blacks, and Asian people again have a lower incidence of myeloma. It is, again, more common in men than in women. And in the United States population, about 19% of all myeloma patients are Black, and that number keeps rising year after year after year. So Blacks have twice the incidence of myeloma as compared to whites. We'll talk about how that is with MGUS. And this isn't just something in the United States, but actually is around the world. The very first, or one of the very first descriptions of a higher incidence of myeloma in Blacks was actually in Jamaica, and then was seen again in South Africa. So this is something of people of African descent. Next slide. And this is from the National Cancer Statistics Database, the SEER database. And you can see that looking at that for Blacks and the incidence of myeloma over the past 19 years has been slowly rising, and Blacks are the top line in the incidence, and again, rising faster than other races and much higher than other races. And because the incidence is higher, that the mortality is higher. That doesn't mean that more people are dying of myeloma, and we'll talk about that, but specifically that because the incidence is higher, the mortality by numbers is going to be higher. Next slide. But this is one of the largest survival disparities in the United States in cancer. And that's really why we're here today, is talk about addressing some of those disparities and how we can hopefully rectify that. Next slide. So let me make my argument to show you that Blacks have a bit of a different disease and a different presentation than whites with myeloma. Next slide. So to level set a bit, all myeloma starts with MGUS, or monoclonal gammopathy of uncertain significance. That's when people have very small numbers of plasma cells, of the precancerous cells of multiple myeloma. It's very common, very common. We'll talk about that in a little bit. And most people that have MGUS, it won't turn into the multiple myeloma. If they have, and the amount of protein produced by those myeloma, those few plasma cells is slight. And again, the risk of progression to myeloma is about 1% per year. So very low risk. If you have more plasma cells in your bone marrow and it's producing more protein, the normal amount of plasma cells is about 1%. If you have less than 10%, it's MGUS. If you have between 10 to 60%, that's smoldering myeloma. And those patients are completely asymptomatic, but they have more plasma cells. And they have a higher risk of actually having the cancer, about 10% per year. And true myeloma is when you have so many plasma cells that it begins to cause problems, that you do a biopsy and you see that there are lots of plasma cells in the bone marrow. Again, it should be 1%. You're talking now something like 30, 40, 50%. And it's causing the CRAB, a myeloma defining event, having a high blood calcium, having low kidney function, having severe anemia with a hemoglobin less than 10, or normals between 12 and 18. And lytic bone disease, where you have holes in the bones caused by the myeloma cells leaving that bone marrow space and causing bone destruction. Those people we need to treat because now it's become a malignancy. Or if people have high numbers of plasma cells in their marrow, over 60%, or if their free light chains of protein being produced by the myeloma cells are very high, or if they have more than one lesion on an MRI, again, with the bone marrow biopsy being positive, we call that myeloma, and we definitely treat those people. But all myeloma starts with MGUS. And next slide. So what we've seen is that MGUS and myeloma does have a strong family, a hereditary component. And this is different than Blacks and in whites, that the excess risk of myeloma seen in Blacks is partially because of family history. That when they did molecular studies, they found that Blacks were more likely to have a family history of myeloma than whites. So it's not so much that myeloma itself is hereditary, but the precursor disease, MGUS, is hereditary. and that is more seen more than blacks and whites. And when they've looked at molecular studies, looking at the difference between blacks and European African Americans, European Americans, there are molecular differences between the myeloma seen in blacks than the myeloma seen in European Americans. Next slide. That higher incidence of myeloma is also seen in the precursor disease, MGUS. We talked about how that is a bit hereditary. And when they looked at people, at U.S. veterans, that blacks had more MGUS than their white counterparts. The good news is that when blacks have MGUS versus white has MGUS, they don't have a worse MGUS. It's not more likely to turn into myeloma. A study called the PROMISE study, which I joined, is a study that looking at blacks over the age of 50 or people with a primary history, a family history of myeloma. I joined the study. I donated a blood sample to them, and they actually have looked at mass spectrometry, which looks for very small amounts of protein, and found that the precursor to the precursor is found more in blacks than they're compared to other races. And so again, the precursor disease to myeloma is seen more in Africa and in people of African descent, which then leads to more myeloma than our European counterparts. For smoldering myeloma, kind of the same thing, but again, the risk of progression is no higher between the races.
So do you think, and I'm just spitballing, like it was maybe I noticed like malaria was a defense, so maybe myeloma, or maybe MGUS, not myeloma itself, because maybe MGUS is a defense for people of African descent.
So, Ellis, we'll talk all night. So you should have asked that question. You really should have asked that question, because we can talk all night about that. But you are 100% correct. That is really difficult to prove. That's a very difficult. So that is molecular anthropology. But you are correct in that. What is the major difference? Why is myeloma more common in people of African descent than people of Asian descent? Is you're right. There were different, and this is a cancer of the immune system, right. And there were different infectious pressures, put evolutionary pressures on blacks than whites than people of Asian descent. So I totally agree with you. That's somewhere deep, and the difference is somewhere deep in the genome. And that's what the PROMISE study is trying to get to, is what is deep inside the genome of people of African descent that had a different evolutionary infectious pressure than our Caucasian colleagues and that our Asian colleagues, that cause this disease of the immune system to be more common. And what we need is a lot more Black people on this study to look at this, to be able to make a determination. But your theory is very sound, very sound. You should come to clinic with me. That is.
I would love to come to clinic with you, because I was thinking about, and for our audience sake, so we don't bore them too much, is that genetic testing, and you can correct me if I'm wrong here, Dr. Cole, is your individual. So like your genetic testing, you're talking about what's happening in your specific genes, and do you are having a predisposition for something that might be family related. Genomic testing is what you're talking about, which is the studying of this genetic of a group of individuals. And so therefore we're trying to see if there is a link in that genome that could be the precursor for the overdevelopment of myeloma in a particular group. And so that's
perfect.
Layman's version of genetic versus genomic.
Well said.
Okay.
And another study that looked at MGUS risk, and again, MGUS, when they did a 12,000, next slide, go ahead.
Okay.
When they did a 12,000 person study, again, they found that MGUS was a common 2% of the overall population has it. and was seen higher in blacks at 3.7% of the population as compared to whites and Hispanics. And they tried to correlate with other risks. And they tried to correlate with tobacco, education, socioeconomic risk, autoimmune disease, chemical exposure. Couldn't find any correlation between the precursor to myeloma, race, and any of those other things. Wow. So that's why we are still looking for the smoking gun of why MGUS and myeloma are more common in blacks. Next slide. And again, obesity may be a component. It can't answer the whole thing. And we're still, again, trying to look into that, because not everyone not all Black people around the world have obesity. And we see this around the world. But again, we're still looking. Next slide. We Blacks do present about 4 years younger than their white counterparts with this disease. We don't know why. More likely to present with anemia, more likely to have the cells dividing very quickly, found by the LDH test, and are more likely to present with the myeloma defining events of high calcium, renal insufficiency, and anemia. Less likely to be found with bone disease than whites, because Blacks have a higher bone density than their Caucasian counterparts. Next slide. The good news is that when they looked at some of the really high risk, so myeloma is broken into high risk and standard risk. High risk myeloma, very, very difficult to treat, very difficult to treat. Several studies have shown that Blacks are less likely to have those high risk, difficult to treat myeloma than their Caucasian counterparts. Less likely, Emory University found that one of the really high risk lesions, amplification of chromosome 1 and deletion of chromosome 17, again, less likely to be found in Blacks than in whites. Again, why that genetic chromosomal difference there is we don't know why that difference exists. Next paragraph. Oh, next paragraph. Next slide. What we do know is that, and this is a really interesting study, this actually, instead of asking people what race they were, this did molecular testing for biogeographical ancestry. So it looked to see how high your African ancestry was, and tried to correlate that with chromosome mutations in myeloma cells, and found that the 11-14, 14-16, 14-20 translocations were higher in people with the highest African ancestry than lowest. And the reason that that's important is that 11-14 is a target for a new treatment for myeloma. That African Americans and people of African descent would probably benefit the most from. And next slide. So now we'll talk a bit about disparities in care. So hopefully I made an argument that myeloma occurs, that MGUS, a precursor disease, is more common in Blacks than all other races. Myeloma is more common in Blacks than all other races. That we present with, that we don't quite know why that biological difference occurs. That the disease occurs earlier, that we're less likely to have the bone disease, but likely to have the other myeloma defining events. And importantly, that we don't have the high risk, we're less likely to have the high risk myeloma, the difficult to treat myeloma. And we'll talk now about actually treating myeloma. And myeloma treatment is broken into basically three quadrants. Is the upfront treatment. So when you're first diagnosed, what we treat you with. And usually those induction regimens, the most common induction regimens I put in yellow. Probably the most common one is the 3-drug regimen, Velcade, Revlimid, and dexamethasone, VRD. Darzalex, Revlimid, and Dex. Another common regimen, and then the 4-drug regimens that are at the bottom, and of course, clinical trials. And so those are the common induction regimens, the standard of care for myeloma, followed by doing some type of consolidation like a stem cell transplant So you deliver a dose of chemotherapy after you receive the induction to really push the disease down. And then patients go on maintenance therapy. And usually they're on maintenance for years and years and years. And then when they relapse, then we have lots of opportunity of lots of different regimens to treat the myeloma with, which is why survival with myeloma has improved so much, from 3.8 years in 1999 and 2000 to now be greater than 10 years with all the new treatments that have come out. But
I want the audience to understand. So there's not a cure for myeloma. Every patient goes through this process of getting diagnosed. Once you're diagnosed, you go through your frontline treatment. Then that frontline treatment, then you have maintenance.
Yep.
And then you'll be on maintenance for a period of time, and then it can relapse, and then now you go on a relapse treatment, and then that process starts.
Yeah, exactly. But those are the standards of care. Next slide. Now there are differences, and when they looked at the utilization of those drugs, those main drugs that I put in between 2007 and 2009, they found that there was significantly lower utilization of lenalidomide. That drug was used over and over and over in those induction regimen part. Significantly lower utilization African Americans, higher utilization of thalidomide, which is a very old drug. A lower use of bortezomib, which again among Asians, which is one of those other drugs in that triplet therapy that I talked about. Hispanics had the longest median days to first bortezomib dose and the lowest utilization of stem cell transplant. And in fact, that stem cell transplant, that consolidation part, has increased for everyone except for African Americans. And the use of stem cell transplant, which is a really important part of myeloma therapy, is associated with better overall survivals in some studies. And when you look at the bottom graph, the top graph showing, how Blacks and Hispanics have lower utilization of the lenalidomide, the bortezomib, and the triplet therapy, and the bottom line again showing that the utilization of the triplet, the standard of care, higher in whites, significantly higher in whites than in Blacks, and stem cell transplant significantly higher in whites than in Blacks. Next slide.
So let me get this straight. So it's higher. The incident rate is higher in Blacks, but yet the higher care is still given to whites.
Yes.
Okay. All right.
We'll talk about that's coming up about why.
I'm just saying, it's like when the numbers bear it out. It's a frustrating thing to see.
Absolutely.
We have a disease state that's impacting us greater. We should have the best treatments available, and even I'm not saying give it more, at least equal it out in terms
absolutely.
Care.
And that's why we're here, because if there's someone that says, gosh, my grandmother was on 2 drugs instead of 3 drugs, then they should talk to their doctor about why aren't they on a 3 or 4 drug therapy for myeloma. And so some of the disparities stem from that people need to talk to people about this disease. It's difficult to talk about myeloma. It's easy to talk about lung cancer because nobody knows what a lung is. It's easy to talk about, when I first started doing research in myeloma, my mom thought, and she's a doctor of education, she thought I was doing it in melanoma. And I said, Mom, being a Black woman, you are 80, I figured this out, 87 times more likely to have myeloma than melanoma.
Oh, wow.
So people know about everyone knows about melanoma.
Yeah.
We don't know about myeloma, and Black people don't get melanoma very much, but they do get myeloma.
Right.
So that's why we need to talk about this. And that's why I thank you for allowing the opportunity for us to discuss this, because how you can break through some of these disparities is people talking to people about it, sharing their experiences and saying, this is how this is how successful treatment looked for me. And then the word spreads, because there's no better way to break down some of these disparities than people talking to people. When they live on their islands, they don't know what's going on. When they're
Right.
part of a community, they know what's going on. That empowers them to make change.
Amen.
So again, Blacks and Hispanics, longer time for myeloma diagnosis to therapy. But when this is one of several studies that when you look at myeloma specific survival, not survival of people, getting bitten by sharks and getting struck by lightning, but
Right.
people dying of myeloma was significantly longer in African Americans than in whites. Part of that is due to that cytogenetics, but we don't know why Blacks tend to do better with this disease than their white counterparts when treated equally. The overall survival was the same between all groups, but again, there were significant delays in both diagnosis, significant delays in induction of treatment, and significant differences in treatment modalities depending on race and ethnicity.
Now, those medications, are they oral? Are they pill? Are they injections or infusions, or how are they administered?
Yeah, a combination of usually the induction therapy does have pills, injections, and IVs.
Okay.
And the maintenance therapy is usually just pills.
Okay.
And when talking about stem cell transplant, again, we know that stem cell transplant is one of the main types of therapy. It's part of the 1-2 punch. You do the induction therapy to get rid of 99% of the myeloma cells. You do a stem cell transplant to give that delivery of chemotherapy to get rid of that 1%. But the number of transplants, the utilization ratio. So they looked at over 22,000 myeloma patients in the United States and around the world, and saw that the utilization ratio of how often were patients given a transplant, with whites having a utilization ratio of 1.1, that Blacks had a 0.69 utilization ratio, Hispanics and Asians below that. And that racial disparity itself prevents 1 in 7 potential stem cell transplants for myeloma. For among Blacks, Hispanic, and Asians, almost half of potential transplants do not occur because of disparity in access. Next slide. And when the National Cancer Database saw that Blacks, Asians, and Hispanics, older age, low income education, residents in metro area, and little to no insurance represented lower likelihood of stem cell transplant, and racial disparity in access to transplant persists even when adjusted for income and education. So and really, I would say that the lack of healthcare insurance can be a barrier to a stem cell transplant. But the bottom line, I think, is the most important. That it is probable that patient and physician bias play a role in the decision to pursue transplant. Because when you put Blacks and Hispanics in front of transplant doctors, they are just as likely as any other race to say that they want to transplant. The problem is that some of the physicians in the community say, and I've seen it, I had to educate our own fellows when they have said, oh, this patient has too many comorbidities. She has too much hypertension. She's too obese for a transplant. And I tell our fellows, that is not your call to say if somebody is or is not a transplant candidate. They should talk to the person that does the procedure to see if they're a transplant candidate. And so one thing that I would encourage is that if you have myeloma and someone says you're not a stem cell transplant candidate, you need to get an explanation of why and get a second opinion about why aren't you a stem cell transplant candidate? Because one person should not be making that decision unless they're a stem cell transplant provider. Next slide. Maintenance therapy, we talked about how that is important to keep the disease under control after people are diagnosed, after they receive their induction therapy. And again, there is underuse of that maintenance therapy among Blacks, Hispanics, and Asians. Whites having the best use of maintenance therapy. And when they looked at the predictors of underuse of maintenance therapy, again, one of the standard of care mainstays of therapy, Black race and Medicaid insurance were the top two predictors of underuse of maintenance therapy. And next slide. And when you look at, again, those bone lesions that occur with myeloma, the standard of care is that everyone diagnosed with multiple myeloma should be getting some medication to help strengthen the bones, because this disease tends to dissolve the bones. That again, there's lower utilization among the races as compared to whites.
So just as a shameless plug, the last show that we did, we talked about how those bones get crunched up, and we even Dr. Cole even showed maybe one of the earliest cases of potential myeloma from hundreds of years ago, that even though they didn't know what it was, when you dig up the bones and they saw the holes, it's more likely that person. So I would encourage you to go back and watch that program. It was fantastic. And really, even though Blacks have more bone density, and so that is one of the least of that crab that we talked about earlier today, if you're noticing one of the early symptoms is bone breakage, right? If you're playing basketball, you jump, you land, all of a sudden you break your ankle on just a simple thing. You're like, okay, what's going on? And we've had former patients come on and talk about breaking an arm, breaking a wrist, breaking an ankle that didn't seem like it was the force was enough to cause a breakage, and that led them down the path of, oh, you have multiple myeloma, and as a result of the bones.
Yeah. Yep. And again, all those are completely preventable by using the bone strengtheners. And one of the big factors, and they looked at outcomes with myeloma. The socioeconomic factors play a big role. That patients who are over age 65, privately insured, lived longer with myeloma than those with Medicare. Treatment at academic centers led to better survival. That statistic drives me a little crazy, because that says that patients at academic centers have a better survival. Some of my colleagues say, "Look how great we're doing," and I say that is a tragedy, because that means that we haven't educated the providers and the cancer doctors in the community of how to treat myeloma like we do at academic centers. But that does say that if you have myeloma, getting a second opinion at an academic center, just getting their opinion about your disease course, is really important. Fewer ages, comorbidities, treatment at academic centers, higher income associated with improved survival with this disease. And again, that insurance, because this disease can be expensive, is that a lot of the disparities we talked about really stem in part due to socioeconomic status. Next slide.
Yeah, I was concerned about that, because I know we're approaching open enrollment, and we have a show on Thursday encouraging open enrollment. And when you see in this particular, so let's not extrapolate this out to all other disease states, but we're talking about this disease state having a Medicare. I feel, this is not any empirical data, but I feel like that could be tied to socioeconomic status, how engaged you are in your treatment plan, which could be impacted by your socioeconomic status, distance. Do you have reliable transportation? Those social determinants that we talked about earlier in this presentation tonight, that it can have an impact, and that Medicare is just kind of one of those factors. So if you have Medicare, please re-enroll.
Yes, absolutely. Next slide.
Yeah, sorry.
Oh, no.
Got a little tangent there.
And next slide after this. And one little point that I wanted to kind of emphasize is that when we make, the International Myeloma Working Group makes the guidelines of how to treat myeloma. and historically there have not been a lot of Black patients on the studies that make up the guidelines, and that's something that and that paper was just published a few weeks ago, and that is something we need to change, is have more Black patients. And I think our next talk is going to be talking about clinical trials and
Yes.
how we need to put more diversity in the guidelines so that everyone can follow, so that when I have a Black patient, a Hispanic patient, I'm certain that those guidelines will work for them, because we did talk about how there are differences in biology with this disease.
Right.
Next slide. The good news is that all things being equal, that Blacks, again, have better and sometimes superior survival. That a VA study that was done, Black patients had superior overall survival compared to whites. Those VA patients with myeloma under age 65, it was even Steven when over the age of 65. And of course, there's no racial disparity in VA coverage. Everybody receives novel agents. Everybody receives stem cell transplant through the VA system. Next slide. And the Emory or RVD 1000 study, where they enrolled 1,000 patients with that 3-drug regimen I mentioned. Again, Blacks had consistent outcomes very similar to whites. So all things being equal, survival is the same, if not better. And next slide. And even the newest therapy, using a 4-drug therapy, which has now become the standard of care. Again, Black patients did very well, had a little bit different of side effects, that they're more likely to get upper respiratory tract infections and edema than their white counterparts. But on this study, where everyone treated with the same regimen, again, very good outcomes for Blacks. Next paragraph. Or next.
I got you.
So how can we break down some of these barriers in myeloma? Next slide. So, one barrier to break down is trust. The fear of unintended outcomes, the fear of mistreatment, the historical stigma, and financial toxicities. And I would say that really addressing those concerns directly and openly. I don't have enough patients who talk to me about the financial toxicity of this treatment. It is really, and I bring it up because there are solutions. And I see at MSU, we see patients of all social economic strata, and we have always found solutions to treat patients with this disease. The trick is to have an institution that has the resources to look for those solutions, that has the social workers and have the financial planners that can help with those solutions to overcome some of those barriers. Discuss your social history. Discuss with your doctor who needs to be in the room to help make decisions, because it is overwhelming to treat and myeloma treatment. So having somebody there with you, talking to your doctor about who's in your family that is your support people, is really important. And again, people should talk about this disease, engage the community with this disease, talk about myeloma, engage nurses, patient navigators, and social workers to assist in your journey, because this is a team disease. This is not a doctor and one patient. It is a team disease. Next slide.
Yeah, and you can also go to LLS.
Yes.
They've been a great partner, and they have access to resources as well to help offset treatments, and they can give you some more information. So that's the Leukemia and Lymphoma Society, for those that don't know. But you can go to lls.org if you have.
Absolutely. And they have been a phenomenal resource, for us being able to treat, to really, help with the copays, and sometimes to help completely alleviate the copays of these diseases. But not everybody knows that. And that's the problem. Right. Is that some people, and unfortunately, some doctors say, well, my patient can't afford that. Well, they haven't tried to see if they can afford it, especially with using some of these copay assistance program, but also getting the community aware about myeloma. because we have limited information of disease. More people know about melanoma than myeloma, misinformation of this disease, language barriers, and really to attend, just like Alice said, attend some of those community engagement education programs that the Leukemia and Lymphoma Society, I do talks for the Leukemia and Lymphoma Society, the Multiple Myeloma Research Foundation, the Health Tree for Myeloma, and I see very few people that look like me. Go to those meetings, learn about this disease, and empower yourself, because that empowerment is how you break down these barriers. When you can, ask your doctor questions and question your doctor about what's going on, so that is a partnership. And you need to talk to other patients. We should ask for culturally appropriate tools, transparent communication, and language between you and your doctor. There should be no barriers in the communication between you and your doctor. And we're working at building guidelines for timely diagnosis of myeloma with community doctors. I just did a talk earlier today with community physicians about how we diagnose this disease, how can we diagnose disease earlier in people of color. And next slide.
And it's a simple blood test, and we learned that before.
Simple blood test.
Three
and then access to quality care. We have barriers, challenges that include, lifestyle factors, logistics of cost and distance, use of technology, competing priorities, local community oncologists versus academic centers. And really, it's not a community doc versus academic center. We all work together. I work with a lot of community physicians when I do second opinions. We work together to treat patients because it's too far for a lot of people to come to see a myeloma specialist. But work with the social workers and clinic support staff for solutions of financial toxicity, because I think we showed that is the major barrier in treatment of myeloma between the races and ethnicities. Find support for transportation, promoting care closer to home. I have lots of patients get their myeloma labs closer to home, get their x-rays closer to home. Telehealth, I do lots of telehealth. All my colleagues are doing lots of more telehealth since COVID. We can do second opinions and reach further than we've ever been able to reach. And again, obtaining second opinions to work with your local physician and how to treat this disease. Next slide. So in conclusion, people of African descent have twice the incidence of myeloma. The biology is different, I think I showed, between people of African descent and European descent. And there are disparities in delivery of care with myeloma, including significant social economic status differences in this disease, really regardless of race. Next slide. But with equal delivery of care, people of color have equal, if not superior, results with therapy. But people of minority race have had a less increase in population survival with myeloma than their white counterparts, in part because of delays in diagnosis, lower utilization of those newer therapies. But we are working on ongoing strategies to mitigate some of those health disparities. Being here today, talking about this disease, what blackdoctor.org is doing is breaking down those barriers. And I would say that one of the biggest ways to get rid of those disparities is become a strong advocate for your health. And next slide. And this is one of my favorite slides, my first and last favorite slide, that now that we're aware, we can't help but make changes. And next slide. And I would ask you to, what Master Yoda has said, to pass on what you've learned. Pass on what you've learned about this disease, about the disparities, so that we can, again, empower ourselves to make change. And next slide. And there's my email address, and that's our hospital.
Absolutely. All right. So there's a comment and there's a question we want to get to here. Dr. Cole, thank you for that presentation. So Carissa Jones said, a renowned young dermatologist, did you hear about this? passed away. I believe he had multiple myeloma. Many were sad about this. He had the best medical care. So, and she said he was African American. So she, again, as Dr. Cole has said in each one of these presentations, uh, people of African descent have a higher risk factor when it comes to developing multiple myeloma, and so that is not surprising to read that. It's sad, but that's not surprising when you say an African American male. Again, that's what the impetus of the name of this program is, Blood Brothers, because that is the highest at-risk group when it comes to multiple myeloma. Larry is asking a question. He says, do you have to ask your doctor for specific tests, or will it show up in your 3-month test from your doctor?
Yeah, that's a very good question. And it won't. You have to ask your doctor for a specific test. So one test is the serum protein electrophoresis. So electrophoresis. So the serum protein, or SPEP is what we call it. And that looks for the protein being made by the myeloma cells. So, and because you don't have to have a bone marrow biopsy in order to see if you have this disease, you do the SPEP test, the serum protein electrophoresis test. And the other test is the serum light chain test. So looking for light chains, the little fragments of protein made by the myeloma cells. And if that SPEP is positive and the light chains are high, then that suggests more testing needs to be done to rule out multiple myeloma. And so, but those they're not part of the usual tests that we use to screen. There's a study that's going on right now trying to figure out, should we, and a PROMISE study is part of that, to see if we should be screening people for this disease. And we don't know yet. We'll have to see the results of these studies to see if we should be screening for myeloma at a population level.
And what I think what Dr. Cole's meaning by that is, like, for example, there is a screening automatically that kicks in. There's a number that says when you're over the age of 40, male, you should have your prostate cancer screening done. And so, or breast cancer after a certain, I think they just lowered it to 40 years old for breast cancer. So there's not a specific screening or date or time or age that they say you should automatically kick in screening for this particular condition, and the jury's still out. I would suggest, this is again layman talking, that when you were having that slide up talking about the people that were in that study to determine the screening guidelines, and there's only 2.3%, I believe that's the number out there, of Blacks that were in this, in terms of 5 million plus people in this study, but only 2.3% of them are Black, of African descent. And it's a disease that impacts more people of African descent. That shows you that the actual screening guidelines could be skewed in one direction when it should be in the opposite direction.
So what we say is that if, and that's what I said earlier today, is that, if you're Black and over age 40, and if you have suggestion of one of those myeloma defining events, if your blood calcium is high, if you have unusual bone breaks, like Alice had mentioned earlier, if you have, kidney problems that can't be explained by other reasons, or if you're anemic, and they say, oh, it's not iron deficiency, it's not hereditary. If you have anemia, screen for this disease, because it's an easy, those tests that I mentioned, those two tests, serum protein electrophoresis and free light chains, will identify 99% of myeloma patients, will find 100% of MGUS patients. Right. And so those two tests are very powerful at saying, look, your anemia is not due to myeloma, and move on. We'll give you some vitamin B12. Or the reason you broke your arm isn't because of myeloma, it's because of such and such. But if it is due to myeloma, then we can definitely treat it. And the treatments for myeloma keep improving literally month to month to month. We had 2 new drugs approved for myeloma and within a week of each other in August. And so things keep getting better with this disease every month, every year.
And that's going to be our next show. But I will say, lastly, Black folks, control your hypertension,
Yes.
because that's how we can get you, because that impacts your kidney disease. And that's the easiest line for a physician to draw. They won't do those tests that we talked about, because they say, oh, your kidney failure is due to your hypertension, uncontrolled hypertension. And so therefore, they're not even going to do those tests that could be potentially coming from myeloma. So please, 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 if you're hypertensive specifically, get it under control. So therefore, we can rule that out when it comes to if you're having kidney deficiencies, and we can do that light chain and the SPEP test. So see where you are in him. Because see, I'm learning, Doc. I'm getting
You
it.
got it. Well, I'll bring you. I think maybe you can wear my white coat.
Well, we both have a similar
That's
look.
it.
We got the similar look. I grow my hair out of my face a little bit because
That's
it's got a little salt in there. That's why I keep it low. So I don't like to get too much salt. But yeah, I would definitely love to come. I won't wear a white coat because I don't want to confuse anybody. But I would definitely love to come up there and tour the facility, because it's very important for people of color. That's why we're doing this series.
Yes.
It's a 6-part series on multiple myeloma, and hopefully, as he said on the slide, the more you know. Now that you know, share what you've learned, share it on your page, let somebody know, and we'll be back in a couple of weeks to do another part of this Blood Brothers Overcoming Multiple Myeloma series. Thanks again, Yanni.
Take care. Thank you.